on the cloud. All right, sorry for that recording whiplash, folks, and good morning. Welcome, welcome, welcome to our last day of the 2023 Overdose Prevention, Harm Reduction, and Treatment series put on by the Washington Poison Center. Folks, we have had such a great time these past couple days. We've had excellent sessions, excellent partners, excellent speakers. I am so excited to see today's lineup. Now, my name is Alex Sorotsky. I use he, him pronouns. I'm one of the educators with the Washington Poison Center. It is my job to go through some housekeeping like we have each session, just to make sure you all know you have all that in mind as we get going. So as you heard multiple times by the voice just now, these are being recorded. So we're going to post the recordings to Whova by early next week. If there's any session you want to revisit or weren't able to attend, you'll be able to do that by next week. Slides will be available a little further out. We'll get those uploaded on our website, on the Washington Poison Center website directly. Now, we are not doing CEs or CEUs this year. However, if you watch at least 5 sessions, either live or recorded, by September 15th, that's 5 sessions by September 15th, we will send you a certificate of attendance. We are going to be sending out a survey at the very end of the series. Please, please, please fill this out. It helps us kind of consolidate feedback for this year. It helps us plan for next year. We're always trying to grow this session into what's most useful for folks and most relevant. So please fill that out when you see it. Now, speaking of next year's series, we have managed to keep the Overdose Awareness series free each of the 4 years we've done it. And we really love the word free at the Washington Poison Center. Our poison helpline is always free. You're never, ever, ever going to get a bill for calling us. Not a single one of our nearly 60,000 patients last year received a bill from Washington Poison Center. And we've educated thousands of Washington residents, all for free. Now, as much as we love the word free, we do unfortunately have costs. Our operations are expensive. So I have to give the donation plug. We have multiple funding sources, and we will always, always, always accept donations of any size. They will always help and literally can help save a life. So we're going to go ahead and put our donation link right in the chat box here. So if you or someone you know or your organization is interested in making a donation to the Washington Poison Center, we'll make that easy for you. All right, now enough of my preamble. I'm going to introduce our speaker today. We have Dr. Scott Phillips joining us. This individual has more letters after his name than alphabet soup. He is board certified in internal medicine and toxicology for over 30 years. He is the executive and medical director of the Washington Poison Center. In addition to his position at the Washington Poison Center, Dr. Phillips continues to work as a hospitalist in Providence Mount Carmel Hospital in Colville, Washington. As a fellow of the American College of Physicians, the American Academy of Clinical Toxicology, and the American College of Medical Toxicology, Dr. Phillips is dedicated to ongoing education and teaching. Focusing on environmental toxicology and health risk assessment, Dr. Phillips has authored over 200 articles, chapters, and abstracts, as well as several textbooks on medical toxicology. Now, I'll stop that intro there because if we kept going and summarizing Dr. Phillips' career, that would take up the whole hour. So with that said, Dr. Phillips, it is all yours. Let's get your screen shared again and take it away.
Okay, how's it look, Alex?
Perfect, looks great.
Awesome. Well, thank you for that kind introduction, Alex. I really appreciate it. And thanks to everyone who's joining this morning. We're so happy that you're all participating in this really important session. We did have a speaker yesterday, Dr. Winters, who talked about prescribing in older patients and medication errors and mishaps. We'll talk a little bit about that, and we're really going to build on her terrific presentation that she did. So with that, we're going to kick it off here. And, you know, prescribing medications that we all do commonly is we like to think of it as a win-lose game, but there's actually a lot that sort of factors into this. Before we jump on, the usual things, no conflicts, of course. Our objectives are really to think about metabolic changes as you age, to think about elder drug dilemmas, substance use disorder in the elderly, overdose and suicide risks as well in the elderly when it comes to medications. So pills are bitter to swallow, and this is the win-lose. We always think of win-win, but there is some downside with medications. And of course, the upside is we hope to improve morbidity and mortality, increase longevity, and doing that, improving ADLs that a patient may have. With aging, however, adverse drug reactions increase with multiple medications being prescribed. The actual way the medications are processed in the body, or their kinetics, will change, and oftentimes slow or change in different parameters, and we'll talk about that. There's increase in adverse reactions with multiple medications. And of course, there's can be an increase in morbidity and mortality. So we have to balance our prescribing risk-benefit ratio. It's always important to think about. So two concepts I want to introduce, and these are pharmacokinetics. We shorten that to kinetics, and this is for you non-pharmacists and physicians out there. Kinetics is just how a medication moves through the body and what the body does with the medication, how it's absorbed, how it's distributed, how it's metabolized, and how it's eliminated from the body. And pharmacodynamics is essentially what the medication does to the body. For example, a blood pressure medication will lower the blood pressure. So that's the dynamic process. And there's a corollary of these pharmacokinetics in toxicology. And so we refer to them as toxicokinetics and toxicodynamics. And we do that because things change in overdose with the body, with the way the kinetics happen, with how the medication moves through the body, as well as how the body can handle that excess amount of medication. They all sort of go through similar phases: the exposure phase, which is the dosing, the kinetic phase where it moves through the body, and then the dynamic phase where it causes some a desired effect or adverse effect, a toxic effect on the body. So words that we use, or you might see in the literature, but they essentially have parallel meanings, just different in the amount of the substance and effects that they might have. Well, what are reasons for patients calling us at the Washington Poison Center and any of the other 54 poison centers in the United States? And most common, of course, is medication error. And this likely is due to a double dosing. I forgot to take my medicine, and oops, I took it twice. Accidental misuse of medication can happen. Of course, self-harm or abuse of medication can happen. We're all familiar with that with opioids and opiates. And then, of course, there can be adverse drug reactions that can either be expected or can be unexpected kinds of reactions. But the vast majority of these in patients over 60 years of age really increase dramatically with increasing age. And this has to do with memory issues, with cognitive abilities, and just simple forgetfulness at times with medication errors. So let's dip into this a little deeper. You know, one of the things that we think about is, you know, what are people exposed to in this age category? And obviously they're exposed to what they're prescribed for the most part. So they're typically prescribed medications for their heart. So we'll see beta blockers or calcium channel blockers, or medications to lower cholesterol or help with blood pressure like ACE inhibitors or ARBs. And of course, things like acetaminophen for discomfort. But we see this changed a little bit, and some of this is early COVID kind of information that we've seen. But the important thing to realize is really beta blockers and calcium channel blockers are widely prescribed. And because of their availability, they tend to bias our population. And there are cases where just one additional dose of certain medications might actually make the difference of whether we will monitor someone at home or send them into the hospital to be assessed. So essentially, it's availability bias. People consume what they have available to them. So this sort of divides that a little bit deeper. And this is double dose, as I mentioned, the wrong medication being taken, the wrong dose, the wrong person, other medication errors, wrong time, wrong route, or a provider error. But you see the most common is a double dose of medication. And that's typically just, oh, I forgot that I took it and I took it again kind of a scenario. And this is where pill minders come into play as long as they're filled appropriately and monitored appropriately with no more than a week's supply. Well, we also need to think about multimorbidity in this age category. And multimorbidity just means, more than two concurrent chronic medical conditions. So you might have heart disease and kidney disease, or a stroke and heart disease, that type of thing, or diabetes and COPD and heart disease. So these are multi-morbid conditions. And, over 80% of people that are 85 years of age experience this. And even people more than 65, 62% of those have multimorbid conditions, and 50% of people under age 65. So it's not unusual to see this. But if you look at those over 85 compared to the 70-year-old group, they have 3 times the rate of multimorbidity. And of course, multimorbid patients are at risk of inappropriate prescribing. They have more medications. They're more risk of drug disease interactions, drug-food interactions, just adverse drug events in general, and of course, medication errors. So the more medications they have, this becomes the lose side of that initial equation. And polypharmacy is a real issue. So this is a study done by Cueto some years ago in 2008, and it looked at this data and found that for people over 65, that 81% used at least one, and 42% also used one over the counter, and 49% also used supplements. So that's important to consider. And then the older you got, the more different categories of medications prescribed over the counter or supplements that were consumed. And they found in their study that at least 4% of those patients were at risk of a major drug-drug interaction. And half of those with over-the-counter medications. So the most prevalent in Cato's study was really males in the oldest age group, and almost half of those involved warfarin or another vitamin K antagonist. But warfarin is typically the most commonly prescribed. So the more aged you are, the more medications you have, the more risk for interaction, particularly in men, and particularly if you're on warfarin or a vitamin K antagonist. Well, what changes? We're going to spend some time on physiologic changes that alter pharmacokinetics and pharmacodynamics in the elders. And so we think about all this as kinetics in the elderly. So let's start with that. And we'll, of course, start with absorption, because that's after you take a pill, that's what happens first. It gets absorbed into the body. As you age, you have decreased pH of the stomach, and you have less acid in the stomach. You have less surface area of the stomach. There's normally folds or rugae in the stomach, and these flatten out and become smoother. You also have decreased GI motility and less active transport of medications. This primarily occurs in the small intestine, where medications are actively moved out of the lumen of the intestine into the bloodstream. Once the medications are in the bloodstream, we think about distribution, how something is distributed throughout the body. So this is like the Amazon truck spreading it throughout the countryside. And the things that alter distribution are total body water, total body fat. The albumin in the bloodstream can decrease, and a lot of medications are bound to albumin and several other proteins. There's a decrease in cardiac output, whether you have coronary disease or ischemic heart disease. There's also a decrease in renal blood flow, and that's about 1% per year after the age of 50. And there's also a decrease in hepatic blood flow. And as you decrease hepatic blood flow, you decrease delivery of the medications to the enzymes in the liver. So once it's distributed throughout the body, then we have alterations that occur in metabolism with aging. You have a decreased first pass effect, and that means less is taken out the first time the drugs get absorbed from the gastrointestinal tract and get first routed through the liver. The liver takes the first bite out of the pie, and this is reduced with aging. There's decreased oxidative capacity, and we're going to talk about that more. And that's just how medications are broken down or metabolized. So that leads to decreased clearance of medications, which increases the length of time medications may stay in your body, or the half-life, and actually the duration of active metabolites. And we'll also talk a little bit about that. Well, then finally we get to elimination or excretion. And with excretion, if the medication goes through the kidneys for elimination, there's a decrease in blood flow to the kidneys, the renal blood flow. There's a decrease in kidney size. There's a decrease in the creatinine clearance, which is a functional measure of how well the kidneys are filtering. There's a decrease in tubular secretion, which the kidney tubules actually will secrete things back into the lumen of the kidney tubules, so they're excreted. So that's decreased. And there's a decrease in tubular reabsorption. So the kidney tubules can't reabsorb things that normally would back into the bloodstream. So normally small proteins are reabsorbed and a variety of other things. And a lot of small molecule medications are reabsorbed. So when you really look at this, this is kind of the downside of aging and why we see such significant changes in medications, both in the primarily the kinetics here, but we'll also see some dynamic changes in the bodies as well. So there will be a quiz on this. I'm just kidding, of course, but we think about drugs being metabolized in two ways, either by enzymes, which we refer to as a phase 1 or typically an oxidative phase, or a phase 2 elimination, which is binding with other things. And that's usually a conjugation reaction with a glucuronide or a sulfur-containing substance. That leads to creation of metabolites. Some of those metabolites are active. Some of those metabolites are actually the drug we're looking at. So sometimes we'll give someone a prodrug like clopidogrel, which is Plavix, and that medication gets metabolized to an active drug. So we call it a prodrug technically, and then it gets metabolized to the thing you want. But sometimes things are metabolized to an active metabolite that you don't want it to be, and you have to be cautious of that. And then, of course, in detoxification, things are eliminated. So the enzyme side of this, I mentioned the oxidative side of this, and the vast majority of drugs are metabolized by the cytochrome P450 system. And you can see that's about 3/4 of drug metabolism happens from, we call it CYP450 or CYP450. And then there's lots of little subenzymes of that I'll get to in a minute. And those are a listing of the other enzymes in the body that will metabolize certain things. The next most important is UDG, glucuronal transferase. But the most important to think about is cytochrome P450. So what happens to cytochrome enzymes and metabolism? What are they? And we're going to talk a little bit about what happens to them with aging. So in the human genome, in the genes, there's at least 57 different cytochromes. And these are organized into 18 families and 43 subfamilies. And they're categorized by letters and numbers. So for example, it might be cytochrome 2E1. So then there's even subcategories. So that's how they're listed by these cytochrome 2, E, and then 1 would be an example. So these are membrane bound hemoproteins as opposed to hemoglobin, which is not a membrane bound hemoprotein. It circulates inside of red blood cells. But these are membrane bound proteins, most commonly found in the mitochondria. And they're primarily involved in detoxification of drugs and cellular metabolism and just maintaining homeostasis from normal substances that are found in the body. So about 80% of oxidative metabolism and about 50% of elimination is by one of the cytochromes in families 1 through 3. So the vast majority of these are in cytochrome 1, cytochrome 2, and cytochrome 3. So that 57 gets shortened down pretty quickly, fortunately, less to remember. But cytochromes are also capable of affecting drug responses. You know, they can influence drug action, safety of them, the bioavailability of them, and of course, drug resistance through metabolism. We'll talk a little bit about this. This can get pretty deep pretty fast, and our goal is not to make all of you cytochrome experts. The goal is really to give you some idea of how things are metabolized and what are those consequences of those risks in the aging population. So if we look at all the cytochromes, the 1 to 3, here we see the breakdown, and we see 30% of cytochrome drug metabolism, and this is in 248 different drugs. We see 30% of those are from cytochrome 3A4, 20% is from cytochrome 2D6. 2D6 essentially you can think of as all of the psychiatric medications, antidepressants, anti-anxiety medications, and things like that. So this just sort of gives you a general visual of them. Now, these cytochrome enzymes can either be induced, in other words, revved up to work faster and better, or they can be inhibited or slowed down or even blocked. Inhibition side is really more common than induction, and this is really the principal mechanism for drug-drug interaction. And it usually involves a competitive interaction with another drug. So in other words, two drugs want to bind on the same cytochrome site, and then they're kind of slugging it out for time in the ring, and that creates a conflict with them, and they can't do their job and be cleared as they should. Cytochrome inhibition can damage biotransformation or clearance, and that really causes higher plasma levels, and that might alter your therapeutic response that you're trying to get to, and it obviously increase the risk of adverse drug events. So the induction side, as I mentioned, it's really revving those enzymes up so they clear drugs faster. And a good example of these are a lot of the anti-seizure medications, particularly the older ones that we're all familiar with, like phenobarbital, for example, is a classic CYP-inducing drug. So the inhibition can be reversible. That means you stop taking the drug, it goes away. Or it can be irreversible at times, like fluoxetine. So while sertraline might cause a reversible inhibition, fluoxetine can cause an irreversible inhibition. And so that drug, when it's stopped, the enzymes need to be recreated. So a competitive inhibition, inhibitor prevents the binding to that target molecule, and that makes sense. A non-competitive inhibition reduces the activity of the enzyme. So one's a blocker and one sort of slows down the activity of them. But both of these can occur as you age. And we think about these inhibitions in kind of three categories. And the idea is they're either strong, moderate, or weak. And oftentimes we will still treat people that have a weak inhibitory drug interaction if they need the medication. But if you have some medications that are strong inhibitors, then we would probably opt for a different medication. So that's how researchers look at these and how we categorize these. And when you do a drug interaction check, whether it's on EPIC, your EMR, or whether you do it on one of the multitude of online drug interaction checkers, this is kind of what they're looking at behind the scenes to make recommendations. Well, I mentioned earlier about active metabolites, and here's a good example of this. And this is risperidone, and risperidone is an atypical or second generation antipsychotic medication metabolized by cytochrome 2D6. Remember, I said that all these sort of, if we think of medications that work in the brain, particularly on different mood disorders, are metabolized by CYP2D6. So you see risperidone, and I circled it, 5% of the parent compound is excreted on change in the kidney. And the remaining inactive compound is eliminated through the liver. So if you look at the primary metabolite, hydroxyrisperidone, which is an active metabolite, in other words, it has a similar action that risperidone does, you see that 60% it is now excreted unchanged in the urine. So you might be thinking when you look up risperidone, it's like, oh, it's not a problem in people that have decreased creatinine clearance or GFR, depending on what you're looking at. It's not a problem, but the problem, of course, rises with the metabolite, where it can have decreased clearance and accumulate, particularly with long half-life drugs such as this. So oftentimes we need to think of both the parent and the metabolite and think about the kinetics of each and how those might be impacting an elderly patient. Just a very brief mention on fall risk increasing drugs. We know the more drugs you take, the more likely you are to fall. And that's through just sedation, dizziness, postural disturbances, which can be related to blood pressure or cardiac output. You might have an altered gait from strokes or other neurologic conditions, or you might just have impaired cognition. And these are the most common things that are related to fall risk increasing drugs or FRIDs. And statistically, about a little over 30% of people over 65 years of age fall each year. And if you're over 70, that increases to about 40%. And that's one of the common questions that's asked on Medicare screening program by your PCP. You know, they'll ask you, have you fallen this year? It's like, I think I've fallen every year. So that happens, but it's important because 20 to 30% of falls in this age group over 65 can result in moderate to severe injuries. Usually that's fractures, and hip fractures tend to be one of the most common. And we see that all the time in patients where perhaps a little over medicated, fall down, break a hip, and that leads to a real negative downtrend in their overall health. Well, some data from 2011, there was almost 700,000 hospitalizations from fall-related injuries, costing about $30 billion of direct medical costs, not indirect, but direct hospital costs to these patients. And as I mentioned, it's always multifactorial. It's typically not just one thing. They have some susceptibility factors, whether that's low blood pressure to begin with or low cardiac output to begin with, and then you combine it with medications that may cause sedation or more postural blood pressure effects, and then it really magnifies this risk of fall risk increasing drugs. So let's get back to the real nuts and bolts of aging here. This is what we're all trying to counteract, but aren't sure why. So in 1957, Seidlitz published this in Scientific American, and this is the first time the mitochondrion is referred to as the powerhouse of the cell. It was identified in skeletal muscle in the late 1800s. So we've known of mitochondria for a long time, but we really realized by electron microscopy in the late 50s that this really was the powerhouse of the cell. So this is where all of those cytochrome enzymes work. This is where cellular metabolism occurs, where you make ATP, where you metabolize glucose and in the presence of oxygen. This is where it all happens. So what happens with mitochondria and aging? And this is a real issue. It's thought that mitochondria were actually a prokaryotic cell that in evolution way back when found their way into eukaryotic, we'll say, cells like people, and brought with them this metabolism capability and formed this commensal like relationship. And mitochondria have this interesting ability to repair themselves. And it can be, if you look on the left side of that circle, it can be a mid-zone fusion where it can split itself in the middle. It can be a peripheral fission, and this is why by Pink and Parkin enzyme splitting off to an autophagosome. And this can ultimately lead to aging of the cell as well, but ultimately sort of repairing the mitochondria. On the mid-zone fission side, it can get rid of an entire half of a bad mitochondria, or it can proliferate and form two new mitochondria to keep things going. And that proliferation side slows a little bit as you age. If we just look at the liver, we see a young, healthy liver in panel A, and we see an aging liver in panel B. And what we see is there's increase in DNA damage. We see there's more lipofuscin accumulation. We see there's a decreased reactive oxygen capacity, and that has to do with the oxidative capacity and cytochrome enzymes, amongst other things. And we also see senescent cell particles, and this can be part of the phagolysosomes that we saw from the previous slide. And you can see how they clump together here and create more damage in a poorly functioning cell and how it accumulates. Well, inside the mitochondria, lots of things happen. We think about 5 different complexes along the mitochondrial membrane, and they're called complex 1 through 5. And different medications can interfere with these ability to move electrons along this pathway. And as you move electrons along this pathway, you're also consuming oxygen, and you're essentially going from ADP to ATP. So you're adding phosphate moiety. So you're creating energy. ATP is energy, and that's what the mitochondria is ultimately creating. But there's many medications that you can see that I've circled here that will impair these mitochondrial oxidative electron transport chain. And common things like metformin in overdose, acetaminophen in very massive overdoses, lidocaine, rosiglitazone, isoniazid, of course, carbon monoxide, cyanide, and hydrogen sulfide were well known. But even propofol can do this on many different levels. So it's important to think about if your patient is getting acidotic, is this something that we're doing to them by giving them medications, or is it something that they took that's creating an acid environment just based on the body's inability to metabolize these drugs? So mitochondria, as they age, they all this plays a role in inflammation, systemic inflammation, and dysregulation of the mitochondrial function leads to aging. And aging mitochondria leads to dysfunction, as we talked about. You get more of the PARC and PINK1 enzyme effects to slice out, try to keep up with damaged mitochondria. And there's some notion of retrograde signaling where there's some feedback trying to improve the ability of the mitochondria. This is another example, a little more complicated, of mitochondrial DNA, where as they age leads to apoptosis and cell death, or removing stress mitochondria or mitophagia, or removing that damaged fragment, or just the retrograde signaling, which is removing particles of the damaged mitochondrial vesicles, and that's with Parkin and PINK1. So they're removed from the cell. So it gets pretty deep, pretty complicated, but it's important to know that aging mitochondria, aging oxidative capabilities from cytochromes are really, really important in aging patients. So again, it's never too often to go through medication errors. What can happen? And these can be dosing errors, lookalike errors. At the Poison Center, we do a lot of outreach, and Megan and Justin and Alex and others will go out into the communities and will show people lookalike medications, what a candy might look like compared to a similar looking medication. So these lookalike errors can happen. You might have two little blue pills and you don't know which is which. And that's why dispensers can be good, but they can also be misused if things aren't put in correctly. Of course, interactions with meds, food, beverages, herbals, there's lots of drug interactions that can occur. Taking other people's medications, either accidentally or on purpose, or it's not unusual to take pet or livestock medications. We all saw that with the COVID years. And of course, inappropriate storage, whether a medication needs to be cooled or not, and then just over-the-counter overuse. And those are commission errors, or what we do. Omission errors is things that we forget. We forget about taking it, we use an incorrect dose, or we forget to follow the prescribing instructions. It's 3 times a day. Well, I'll just take it twice. I don't really want to take it 3 times. Improper timing when you take it morning or evening, or you mistake the drug for something else. There's lots that's been written about prescriptive errors, but as you saw from that slide earlier on, most errors are errors of omission and commission by patients. But there are prescriptive errors, make no mistake about that. And the more doses a day, there's frequency errors, there's more chance for errors. Substitution errors, and this might be, it was a real problem with handwritten prescriptions where nitroglycerin for nitrofurantoin, diazepam for diltiazem, you can see how substitution errors. And now that we write prescriptions through our desktop computers or laptops, you can see that clears up the spelling, has helped a lot. Double doses, duplication errors, drug interactions, misuse or medication abuse. And we try to correct this by medication reconciliation in hospitals and hopefully in clinics as well, if they have staffing for that, to prevent a lot of these prescriptive errors and omission and commission errors as well. So just as I hesitate in the middle here, I just want to give you some ideas about helpful ideas, so, be really mindful of the power of prescribing. It's a deadly practice. We can really hurt people, and we really have to think about it. As a toxicologist, when I'm wearing my toxicology hat, my goal is to take people off of medications. When I'm an internist, it's to try to prescribe an appropriate amount of medications without causing adverse effects. And so it's a bit of a conundrum, and you should always be mindful of that power. Always use a drug interaction checker, and this is built into Epic. And if you don't use Epic as your electronic medical record, of course, then there's lots of free online interaction checkers that you can use. Be aware of high risk medications like vitamin K antagonists, warfarin, hypoglycemic drugs. Dr. Winters talked a lot about that. And things like digoxin that have a lot of drug-drug interactions. And by all means, consult your pharmacist, whether you're a patient, whether you're a professional, or whether you're a prescriber. Use the pharmacist. They are a wealth and a fantastic source of information. Also think about liver functions and renal function tests. But they don't always tell you whether a patient will respond and will they respond adversely. So just seeing liver function tests doesn't mean that a patient's going to metabolize something normally. There are ways that we can look at metabolizing capacity of people. They're rarely done. There's a lot of genetic testing to look at this, whether you're a fast or slow metabolizer. It tends to be expensive. It's not always specific to one drug or cytochrome. And so we have to be a little cautious about that. And most often, if we're seeing an adverse effect, that we'll withdraw that medication and pick something from a different class. So we have to think about abuse versus misuse. And this is a common area in older patients. Misuse of medication is that you're taking a drug to treat a specific ailment. So you have something on the shelf and you're just taking it without advice. Abuse is using a medication to elicit a feeling. So I'm feeling down, much like alcohol. You could think of it as a drug to elicit a certain feeling. So that's kind of a difference there. Well, let's jump into substance use disorders in the elderly. It's important to think about there. This is a really interesting study looking at 61 million Medicare beneficiaries in 2020. And there's about 1.7 million were estimated in that to have a substance use disorder. So 8% that were less than 65. And only 2% over 65. So overall, about 77% of those had an alcohol use condition, 16% had a prescription drug use condition, and 10% had a marijuana use condition, is how it was defined. So 11% of them in 1 year had received treatment for their condition. So the reasons that people would not receive care, what this survey told us was 41% were not motivated, or there was financial barriers, which also is a link to logistical barriers like transportation. Some people are just concerned what their peers might think. And it's interesting, we talked about young people, peer groups, and what people might think of them getting counseling. When we talked about depression and suicide risk in teenage years before, I think on day one. And the same is true with all age groups, and it's certainly true in this age group as well. So, Medicare beneficiaries with substance use disorder are more than twice as likely to have serious psychological distress without substance use disorder. And so it's really an important thing to think about. This is a common problem in the elderly. I've had too many patients to name that essentially say, don't take my oxycodone away. That's the only thing that keeps me going or keeps me alive. And it's pretty interesting. If you look at the prevalence of past year alcohol or drug dependence in these Medicare beneficiaries, you can see that alcohol is the most common, opioids are common, heroin, marijuana, tranquilizers, etc. I think one thing I'd like to point out is methamphetamine, where it is at 8.2% for less than 65 and 0.3 for over 65. I can't tell you the number of patients I've seen in the last year who have started using methamphetamine when they're at least age 60 or over. It's quite common and surprising. And the same is true with fentanyl. And fentanyl essentially kind of makes sense. People aren't able to get their opioids prescribed like they previously had, and so they just switch to a cheaper alternative with fentanyl. But methamphetamine, of course, is a dangerous creature in people that are older, that have a lot of vascular disease, at risk for stroke and heart attack. So the scope of substance use disorder in older, as I mentioned here, there's some thought that by 2030, 20% of the population age 65 and older may have a substance use disorder. That's thought to be because of aging baby boomers who are going to constitute the highest percentage of that category, and essentially have taken it with them from the 60s into their late years in life. So the free living age of the 1960s is going to come back to haunt healthcare providers here in the next 10 years. Well, if we look at the risk factors here in older patients, tends to be males, which have more alcohol. Females, it's more prescriptive use. Tend to be Caucasians, tend to be born between 46 and 64, the boomers. Tend to have higher income, tend to live alone, very commonly have lost a spouse, or they were retired unexpectedly or laid off. Or they have chronic pain or some disability. Some have a history, of course, of substance abuse or mental illness. So these tends to be common risk factors in this age group. Well, suicide in aging population is also important. An interesting paper published from Stanford and UCLA in JAMA Psychiatry this year, compared rate of drug overdose fatalities in patients over 65 years of age from 2002 to 2021, and they found a four-fold increase from 3 per 100 to 12 per 100,000. So a significant increase. But I think the most dramatic and frightening number with the study is that non-Hispanic African Americans, their rate is 30.9 per 100,000. So it's even 3 times higher than what happened in the general category. So drug overdose fatalities are exceedingly common, and I'll leave the reasons for that, and of course the treatment of that to my social work and psychologists and psychiatry colleagues. If we look at the National Council on Aging study, the idea that older adults comprise 12% of the population, but they make up about 18% of suicide, so it's a disproportionate high risk. And in 2020, there was 46,000 suicides in the United States, and over 9,000 were people in excess of 65 years of age. So older adults, according to this study, plan suicide more carefully, and they tend to use more lethal methods. And this would also include gun-related suicides as well. So among people who attempt suicide, the statistic from this is 1 in 4 seniors will succeed compared to 1 in 200 youths. and the elderly are less likely to recover from an attempt. Overall, men greater than 65 face the highest overall rate of completed suicide. So it's an important problem in aging with medications and prescribing to them. Risk factors, we kind of reviewed them before. I think the other things to think about would be some of the depressive disorders and mood disorders that go with this, perceived burdensomeness, that I'm a burden on my family or community, isolation, and of course, some of the other things that I mentioned, including frailty awareness, people that are just aware that they're frail and declining and they just don't want to live like that, which is a common thing that patients will tell me. So protective factors, factors that increase resilience in older adults, good health, cognitive function, people that tend to have more religious practice in their life, people that have what they perceive as a good quality of life and satisfaction, people that are able to perform ADLs, people that are still married, people that are socially connected, and pets decrease the rate of suicide as well in this group. I'm not sure about that in younger patients, and so if any of our colleagues in the audience have any ideas about pets and suicide in younger patients, I'd be curious to hear that. So in Washington State, we know that half of all suicides are firearm related, but we see poisoning as a common cause, and that is an important thing to remember as we are in the middle of International Overdose Awareness Day. So this just looks at age and race of suicide by group, and this is in Washington State. You see that males have an increasing rate of suicide in each category. And you see that the groups with the highest rates are American Indian and Alaska Natives, followed by Caucasians, multiracials, and down the line. And so those are just some observations from the state database. Rate of suicide by county, I know that Dr. Graves talked a lot about this on her initial talk, and she talked a lot about Ferry, Stevens, and Pend Oreille counties. And so I'll also give a shout out to Chewelah and Colville, where I was raised. These areas that are darker in color have higher rates of suicide. And so essentially these are rural communities, much like what Dr. Graves talked about in her presentation. But it's more than that. I mean, these rates also have higher rates of opioid use, higher rates of fentanyl fatalities, higher rates of smoking, lower rates of socioeconomic status, higher rates of tobacco use. There is higher risk in many of these rural counties, and that's one of the things we've been doing the last couple of years, is trying to really reach out to these rural communities to support them. As Alex did, we mentioned in the intro, you know, we serve all counties of the state free of charge 24 hours a day, and we're happy to help the public or professionals in any way we can. So something to think about. So as far as prevention and treatment, it's provider awareness, thinking about this, thinking about medication, thinking about the power of the prescription, and of course, thinking about mental health access and support is really an important part of this whole process. Many of the prescriptions are following the Beers guidelines, and Mark Beers, who unfortunately passed away of colon cancer, started this, and now it's part of the American Geriatric Society. And the whole idea behind Beers criteria is they label medications that are more likely to cause adverse drug events. I'm a little behind here, so I'm going to pick up the pace, Alex. 1% of hospital admissions are caused by drug interactions. 15% of people admitted to a hospital have at least one drug-drug interaction. Outpatients, the potential is up to anywhere from 20 to 100% of drug interactions, mostly when it comes to herbals and over-the-counter medications. So it's really a common scenario. Here's some common examples of drug-drug interactions that you might see, and we mentioned those early on. And again, these interactions oftentimes are related to cytochrome P450, primarily cytochrome 3A4, and their substrates. I think the last thing I want to mention is that pharmacists have a terrific tool that they use, and that's called medication therapy management. And this is where pharmacists will review medication prescribing, including OTCs and herbals, by talking to patients directly, also talking to their providers and trying to come up with a good managed plan for them. And pharmacists, well known amongst pharmacists anyway, that they can bill Medicare for this. And the whole idea is to reduce these drug-drug interaction and this almost $30 billion excess in cost of these drug-drug interactions. So with that, I just want to say, always think about sharing your decision-making. Consult a drug interaction checker, consult your pharmacist, consult a colleague, call the poison center if you're not sure, but share the decision-making. Phone a friend, as I mentioned before, the pharmacist, a geriatrician, helpline, or a regional poison center anywhere in the United States. It's the same number that's in the lower right corner there. We all have the same phone number, and it just gets routed to the region. So with that, I want to show you the purple ribbon indicating overdose awareness symbolism for today, and I want to thank you for your time.
All right, thank you so much, Dr. Phillips. That was excellent. Well, I'm keeping an eye on the Q&A box. I'm seeing nothing there now. Folks, if I put this in the chat box, but you can hear it now too. Feel free to ask any questions you have, and even if we don't have time to address them live right now, we will go ahead and follow up in the chat box, in the Q&A box through the Whova platform. While folks are thinking, Dr. Phillips, one question I've been asking most speakers who I've interacted with, I'll ask you as well, is if someone just saw the title of your presentation but didn't actually watch the whole thing, didn't have a chance to tune in, what is one action item you'd like them to take away? What's one thing you'd like them to do from that?
Well, for patients, the one thing I'd like them to do is talk about their medications with their provider and with their pharmacist. Try to get everybody on the same page, try to be your own advocate, and really try to prevent any of these things from happening.
Absolutely. And thank you again, Dr. Phillips, for the adding the ribbon there, the reminder that today, August 31st, is International Overdose Awareness Day. And that's part of what actually inspired us years ago to start this particular series. All right, keeping an eye out on the chat box. Nothing coming in yet. Be sure, folks, at 9:30 to go ahead and tune into our next session. That is the science of medications for opioid use disorders. All right. Well, Dr. Phillips, is there any last bit of anything you'd like to leave our audience with before we go ahead and switch sessions?
Well, I just want to thank everybody for joining, and you'll be hearing from me later today, but it's really a terrific conference, and I've tried to join almost every lecture so far, and it's just been terrific. So I learned something with every speaker. So thanks for putting this together, Alex.
Thank you, and big thank you to a lot of my colleagues who were the bigger brains behind this than I was. All right, folks, well, I'll go ahead and end this particular session, and I'll see you at 9:30 in the next one. Thank you again, Dr. Phillips.
Bye-bye.
Bye.